Thank you, everyone. Today's conference is composed of 4 sessions with invited speakers and discussants from 6 different countries in the US and in Asia. Each session will be moderated by esteemed faculty members from the College of Public Health with professional and practical experiences in the relevant fields. I would like to introduce the moderator for the first lecture, Professor Chen. Professor Chen received his Doctor of Medicine degree at National Taiwan University and a graduate degree for Doctor of Science in Epidemiology from Harvard School of Public Health. He's also the former dean of the college for 6 years until 2017. During his stewardship, the college has become the first in Asia that has been accredited by Council of Education for Public Health. So let's give a warm welcome to Professor Chen to host the session, The Future of Aging, a Public Health Perspective.
Good morning. Since the VP has left, so we can relax a little bit. Because, the best way to celebrate our mentor's birth anniversary, is to be networking and work together. I think that's very important. And so you can realize that we arranged the whole conference very different from traditional academic conference. So we like to do a lot of dialogue. So all the speakers will not deliver a long speech, just short. But then we have some discussion, and then we also will be open to the audience. So everybody can raise your point after the delivery of the speech. So now let me introduce Michelle Williams a little bit before he delivered the first KP Chen Memorial Lecture. To many people, Michelle is also a legendary herself. The reason is Michelle migrated from Jamaica to the United States when she was a child, okay? So she was not born in the US. But then she grasped the opportunity to strive for excellence in education. And I have the honor to be enrolled in the doctor program in epidemiology, at the same year with Michelle. So we share the same doctor student's office. And, Michelle was smarter than me. She graduated 1 year earlier than me. And after she graduated, she moved to the East Coast. So eventually, she served as the head of the epidemiology at the University of Washington. But then, probably 6 years ago, she was recruited back to Harvard School of Public Health and become the chair of the Department of Epidemiology. So when I visited Michelle in 2013, and that's we met together after more than 20 years ago. And so she introduced me to her director's office. The first thing she did was she pulled out my doctoral dissertation, okay? So remember, students, don't write anything rough for your dissertation because the institution are going to keep the dissertation as record. So she opened my dissertation and said, see, for our school, those doctor students graduate with the Doctor of Science, our jewel of the crown. So she told me this. So as you can see, she emphasized the importance of a good education, a good research as a good basis for public health practice. So today, we are very honored to have Michelle to deliver the first KP Chen Memorial Lecture. And as Dean Chen already said, Michelle was appointed as Dean in last July by the first female Harvard president, and to serve as the first African American dean at Harvard University. So now let's welcome Michelle Williams.
Thank you. Good morning, everyone. I'm deeply honored by Professor Wei Chen's invitation to deliver the first KP Chen Memorial Lecture. I would also like to extend my thanks to the Chen family and the foundation who made today's gathering possible. I'm delighted and grateful to Dean Chen and everyone at the memorial at the National Taiwan University for organizing today's conference and for your warm welcome here in Taipei. It's truly humbling, deeply humbling to me to be asked to speak before so many of my eminent colleagues from across the region. Professor Chen is one of many distinguished Harvard Chan School alumni with us here today. He and I also share other bonds, as you heard. We were Harvard students at the same time, both studying epidemiology, and both went on to become deans of great schools of public health. Although I have to say, even though I graduated a year before you, Wei, you were far ahead of me on becoming the dean. Congratulations. As you know, my dear friend Wei and my competitive partner stepped down as dean of NTU's College of Public Health just last July, after serving 2 consecutive 3-year terms, but not before accomplishing a remarkable achievement. Under his leadership, NTU became the first school of public health outside of North America to become accredited by the Council for Education on Public Health. That's CEF. I want to offer my personal congratulations on this milestone. Congratulations. Today, we celebrate the anniversary of Professor K.P. Chen's 100th birthday. The Harvard Chan School of Public Health is just a few years older. Our centennial year was just 4 years ago, and you might say that Professor Chen and the school came of age together. Their stories also overlap. In 1960, as you heard, Professor Chen came to Harvard as a young scholar. 10 years later, just 10 years later, he returned to deliver the Cutter Lecture on Preventive Medicine. I was curious about what he'd said, and so I asked a number of my colleagues and our librarians to see what they could find, and if they could find a copy of his remarks. Sure. Thank you. Thank you. Perfect. Thank you. So as I was saying, I was curious about Professor K.P. Chen's remarks made in 1970 at our Cutter Lecture. I couldn't, however, come up with his lecture. They could not locate the document, but they were able to identify the dinner menu in celebration. So I thought I would share that. So those of you who haven't attended Harvard Chan events know that we try to practice what our nutrition department teaches at our dinner table. We don't go as far as some would like. I know Walter Willett would like us to go much farther, but I think along the lines, we push to remove salt, for example, in the school's cafeteria, and the resulting protests ensued. But we still do make an effort. Okay, so what were we serving in 1970 at K.P. Chen's Cutter Lecture? The dinner menu for that lecture featured filet mignon with béarnaise sauce, a stuffed potato, baked potato, bisque tortuni with Grand Marnier sauce, and for libations, they served martinis, scotch, bourbon, sherry, and wine. Reading this list, I can't help but hope that dinner came long after the lecture and not before. But back to what brings us here today. During his remarkable career, Professor K.P. Chen explored issues ranging from cancer epidemiology to the genetics of twins to health problems of the elderly. He was a renowned expert, as you heard and saw on the film, on Blackfoot disease, a terribly debilitating and often fatal disease endemic in an area of Taiwan's southwestern coast where artesian well water had high concentrations of the heavy metal arsenic. But of all of his accomplishments, none was more far-reaching than his contributions to public health education in Taiwan. The fact that the Harvard Chan School has more alumni in Taiwan than any other Harvard graduate school, that's more than 250 alumni, is no doubt one reflection of Professor K.P. Chen's lasting legacy. Many have taken their own place in public health education, carrying on this legacy forward. Wei Chen is one of the most notable, but there are many others, and I shall say they include Dr. Wei Chen, Jenny Su, the first female president of National Chen Kung University in Tian in its 83-year history, and honored last October with the Harvard Chan School's Leadership in Public Health Practice Award. There's also Dr. Wei Shun Chen, Dean of the School of Medicine at National Yanmin University here in Taipei. There is also Cheng Shun, who succeeded Wei Chen as Dean of this school's College of Public Health at NTU and now holds the position. There's also Dr. Shili Ru Chen, who served as Dean of Taipei Medical College from 2004 to 2013. Beyond the academic environment, Harvard Chan alum have assumed more leadership role on a greater, larger public stage. In September, William Lei, an MPH graduate from 2002, was named Taiwan's premier after 7 years as mayor of Tian. And Professor Jing-Chun Ye, now president of K.P. Chen Preventive Medicine Foundation, is a former minister of health for Taiwan. And Dr. Ye is a sponsor of this conference, for which I am deeply grateful. I should also make clear that this isn't just a one-way street. Far from it, indeed. The Harvard Chan School has benefited immeasurably from its close ties to Taiwan. One singular example that comes to mind is the K.T. Lee Professorship, a generous gift to the School of Public Health from the Harvard Club of the Republic of China. This is truly a gift that keeps on giving. The chair was first held by none other than Professor William Zhao As you probably know, Professor Zhao is one of the world's leading experts on designing healthcare systems, and he played a key role in establishing Taiwan's national health insurance system in 1995. The KT Lee Chair is now held by Professor Ashish Jha, a healthcare systems expert who heads Harvard's university-wide Global Health Institute. The institute was launched in 2011, and it works to leverage the vast expertise across Harvard to promote advances in global health research and education. In this way, we can say that Taiwan is at the epicenter of the entire university's effort to tackle the world's most critical health challenges. Now, I want to switch gear and talk a little bit more about the theme of this conference today. The theme is population aging and global health. I was so excited when I learned of this. Since becoming dean in just over a year ago, I honed in on 4 key research priorities, areas of urgent need where Harvard Chan School is positioned to have outsized impact. Aging and longevity is just one of these 4 priority areas. It's fitting that we're addressing this issue as we celebrate what would have been Professor K.P. Chen's 100th birthday. Once almost unheard of, 100th birthdays are something we are seeing more and more of. Indeed, centenarians are the fastest growing segment of one of the world's population, with an estimated 450,000 among us today. In Taiwan, the number is increasing faster than the global average. That is more than 44% increase between 2010 and 2015. Today, Taiwan's population is aging at more than twice the rate of European countries and the United States. But if centenarians remain rare, they point to a new and pervasive reality. The world is on a cusp of an unprecedented demographic transition. Lifespans are longer than ever before. Fertility rates are falling. Soon, people over the age of 65 will outnumber children for the first time in human history. Age distributions in many countries once formed a pyramid with billions of young people at the bottom of that pyramid and far fewer older survivors at the top. That distribution is shifting, and it's shifting rapidly. The pyramid has now become a square, and this is not simply a momentary blip. It's widely predicted to become our new normal. This transition, this demographic transition, is happening more quickly in Taiwan than in most other places. You probably already know that. In recent years, Taiwan's fertility rate has been among the lowest in the world, while lifespans are at or near record highs. By 2050, it's predicted that almost 40% of Taiwan's population will be age 65 and over. Contrast that with just 7% in 1993. That said, while Taiwan is on the fast track, it is certainly not alone. All aging societies, and that includes the US, by the way, share certain fundamental questions. The questions are, what does it mean to age successfully? How can we assure that lives are not just longer, but also healthier? Can a sense of purpose and fulfillment in life help us preserve health into old age? These are important questions. These are questions our public health scholars have to pivot towards answering, and answering rigorously and quickly. As we grapple with these questions, there is much talk of what comes to be called healthy aging. The topic is debated at global conferences and explored in a seemingly endless stream of media reports. But what do we mean by that term? What does aging, healthy aging, look like? Well, I want to start with the World Health Organization's definition of health, and then we can go from there. The World Health Organization's definition has been the same since 1948. The definition of health is as follows. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. In that definition, there is no reference of age, no suggestion that this definition pertains only up to the age of 60 or 70 or even 80. To the contrary, that definition of health is universal and unequivocal. We see this too in the criteria for successful aging proffered by the MacArthur Foundation's Research Network on Aging Society. Along with avoidance of disease and disability, the MacArthur Foundation's Research Network on an Aging Society includes, in their definition, maintenance of mental acuity, physical activity, and social interaction. This is a vision of life well lived, regardless of age. So how do we move toward this definition? It's helpful here to reflect on the concept of the demographic dividend. This term, demographic dividend, was coined by Harvard Chan School's David Bloom back in 2011. The Time magazine dubbed David Bloom's term, demographic dividend, as one of the 10 ideas that would change the world. Simply put, the demographic dividend speaks to the economic boost that often follows when countries shift from high rates of fertility and mortality. For example, where women having lots of children, many of whom died young, towards a different demographic trend that is characterized by low birth rates and longer life expectancies. This is what we've been seeing in the developed world, which in the course of 30 years has resulted in adding 30 years of human life expectancy. At the start of the demographic transition, we see a youth bulge in the working age population. That's because women are still having lots of children, and those are surviving longer. With the right policies in place, this can lead to a surge in economic productivity. This is the first demographic dividend, and it is what happened in most and much of East Asia starting in the 1980s. With economic development comes improved healthcare and public health campaigns. These, in turn, lead to longer lives, and this new longevity tends to give rise to a second demographic transition, or demographic dividend. This comes in the form of increased savings rates as people come to see that they need to plan for old age. Now, we are fast moving towards yet another great transition. Much focus is on the potential downsides of aging populations, slowing economic growth, growing strain on existing pension and healthcare systems, and a greater burden on younger generations. All of these are indeed legitimate concerns. However, at the same time, we must not let challenges blind us to important opportunities. My colleague, Linda Fried, who is Dean of Columbia Mailman School of Public Health in New York, has gone so far as to suggest that we might be able to find a third demographic dividend in the world's aging population. In her view, older people represent a vast resource, what she calls a trust fund that all generations can draw upon to their mutual benefit. In support of this view, Dr. Fried cites evidence that older adults in the US contribute the equivalent of $162 billion a year through volunteering and informal caregiving. Whether you find Dr. Fried's arguments convincing or not, one thing is crystal clear. Healthy aging starts with healthy living and good lifelong health, and good lifelong health care to support that health. Both are critical in keeping older people healthy and active for as long as possible. The goal is what we in public health call compression of morbidity. That is, where fewer unhealthy years are lived near the end of life. Taiwan, always progressive in the space of public health, took huge strides in this direction with creation of the National Health Insurance. As I mentioned earlier, our own Harvard Chan School, Bill Zhao, played a key role here, leading a task force that designed the system. What an achievement. What an important achievement. Today, virtually all citizens have comprehensive health care. I just learned that the percentage is 99.8% coverage. That's universal. We won't quibble about the 0.2%. There's always a little bit of error there. That's really remarkable, amazing accomplishment, compared to just some 57% before the implementation of the system. I can only hope that the United States will someday follow in your footsteps. We owe that to the people of the United States as well. Of course, critically important though it is, healthcare coverage is just one part of the equation. Another crucial factor is lifestyle, our habits and the environment in which we live, work, and play. The foods we eat, the air we breathe, the water we drink, whether we smoke, whether we exercise, such factors can reduce or increase our risks for a myriad of chronic diseases, including cancer, heart disease, diabetes, and increasingly Alzheimer's. Such chronic conditions have supplanted infectious diseases as the biggest global killers. This represents a shift often referred to as the epidemiological transition. It is not that epidemics have gone away. Indeed, due to rapid air travel, diseases such as SARS and bird flu have the potential to go global more quickly than ever before. but infectious diseases in general no longer pose the same threats that they once did a century ago. The importance of habits and the environment point to profoundly interdisciplinary nature of public health today. As I said earlier, aging and longevity is just one of 4 areas we've identified as research priorities at the Harvard Chan School of Public Health. The others are climate change and sustainability, healthy weight and wellness, and trauma and resilience. And each of these has a direct bearing on aging and longevity. To cite just a few examples, let me share the following. Extreme weather events, such as this year's devastating floods in South Asia and the hurricanes that ravaged Puerto Rico, take particular toll on vulnerable populations, particularly the elderly. Healthy weight is tied to good nutrition, one of the critical building blocks for a healthy aging. Resilience is fostered through strong social bonds, also key to healthy aging. Against this backdrop, I want to turn now to work underway at the Harvard Chan School, just to share with you some of the work our scholars are engaged in. One of the many things that distinguishes our schools is excellence in both laboratory research and in the population sciences. As we like to say, our work extends from the genes to the globe, and this is fully evident in our work on aging and longevity. Physical decline is often seen as an inevitable part of aging, like a car gradually rusting as it grows older. Bodily deterioration is seen as the unavoidable result of numerous tiny hits to the system. Genetic, cellular, metabolic, environmental, stress-induced hits to the system. But recent research by our own Professor James Mitchell and Will Mayer and others at the Harvard Chan School suggests that this traditional view of aging may not be correct. The new thinking is that the disorder we associate with aging may be linked to the biological mechanisms of aging itself. This new way of thinking opens up new avenues for exploration. Key questions in this new paradigm of thinking about the biology of aging include: why are we more likely to get diseases when we're older than when we're young? How can we shift the risk of frailty? And what can we learn from centenarians who tend to die from different causes than those who die younger? People who make it past the age of 100 usually decline swiftly at the end to a broken hip or a bout of pneumonia, but not from cardiovascular diseases or malignancies or neurodegeneration. These are important questions and observations that we have to explore going forward. Along with such work, we are moving to combat Alzheimer's disease, an increasingly common cause of death worldwide. Globally, Alzheimer's is estimated that globally, it's estimated that 46.8 million people have dementia. That's approaching twice the population of Taiwan. One of the leaders in this area is Albert Hoffman, my successor as chair of the Department of Epidemiology. Professor Hoffman's work aims to better understand the biologic processes through which Alzheimer's progresses and through which it can perhaps be altered. On a positive note, emerging research suggests that the rate of new Alzheimer's cases are on the decline, at least in the US and in Europe. Professor Hoffman suspects that this may be tied to the fact that we are also seeing better heart health, a condition linked to healthy habits such as exercise, good diet, and reduced or no smoking. Yet another reminder that healthy aging is part of a larger fabric of public health. The link between aging and diet merits special note. Professor Frank Hu, who chairs our Department of Nutrition, believes that healthy plant-based foods can improve vascular health in both the heart and the brain in ways that, among other things, reduces the risk of Alzheimer's disease. In a 2014 study, Professor Hu found a correlation between what is known as the Mediterranean diet, that is, a diet that emphasizes vegetables, fruits, and fish. And what he did was he found a correlation between that Mediterranean diet and telomere length, a key biological marker of aging. Exciting evidence that diet may have the potential to turn back the body's aging clock. Very exciting. Ideally, healthy foods, healthy habits are established early. But even older people can reduce their risk of chronic disease and death by changing what they eat. Of course, life cannot be extended forever. But even if the end of life is inevitable, we do have wide latitude to shape the experience of death and dying. Traditionally, medical practice has acted on the view that prolonging life is the single most important goal. But should we be giving patients greater scope to make their own decisions in this space? When we do, we have found that their choices often make their last days fewer, but they also make them better. These issues around end of life are at the heart of the best-selling book by Harvard Chan's Atul Gawande. The book is entitled Being Mortal, Medicine and What Matters in the End, and it makes a powerful case for patient autonomy. Atul Gawande's pioneered the life-saving safe surgery checklist. You may have heard of this. This has been currently used now by a majority of surgeons providing care around the world. But as he tackles the issues of aging and longevity, Atul has been making similar efforts to think and help us reshape how doctors, patients, and families think about the end of life and care in this period. That said, old age is not simply a prelude to death. Quite to the contrary, many and more, old age is becoming recognized as a distinct developmental stage, one that has both unique challenges and unique gifts. Once viewed as a preliminary and primary individual matter, the realm of physicians, not society, old age is now squarely in the realm of public health discourse. These are uncharted demographic waters for sure. What healthcare policies will best serve us in the long run, given the new and permanent reality of an aging world? It's an important question. What should retirement look like? How do we meet the needs of an aging population without overwhelming available resources? Harvard Chan's Professor Lisa Berkman and Professor David Bloom are among those tackling these population level and policy questions. We know that a key to healthy aging is strong relationships, and this is an area of research explored by Harvard's Ichiro Kawachi, and he goes as far as saying that these are important, the social connections are important for healthy aging, as is diet and exercise. Professor Kawachi has research evidence to support this claim. In one study conducted in Japan, he looked at the effect of membership of so-called sports clubs on people 65 years and older. These sport clubs are organizations that blend socializing with physical activities such as walking, lawn tennis, and croquet. What Professor Kawachi found was truly fascinating. He found that those who belonged to sports clubs and didn't exercise fared better health-wise than those who exercised alone. Interesting. His conclusions? A sense of belonging was a better health predictor than physical exercise alone. That said, do keep in mind that the healthiest of people were all of those who both exercised and socialized. So keep that in mind. All of this work is yet another reminder that aging is not simply something that happens to us. It's a social experience that we can shape and are shaping. It is up to us to shape aging for the better. In old age, as throughout life, we must focus on enhancing the good, not simply preventing the bad. Focus on enhancing the good, not simply on preventing the bad. Which is why I am so deeply thrilled about our new Lee Kum-shung Center for Health and Happiness. This center is headed by Harvard Chan faculty Vish Vishwanath and Laura Kobzanski. And the center supports research to identify the psychological, social, and emotional strengths and assets, an emphasis on the positive assets that may protect people against disease and enable them to live longer, healthier, happy lives. Which is, after all, the whole point. In aging, as throughout public health, it is why we do what we do every day as public health scholars, practitioners, and students. And before I close, I just want to say I am so deeply honored to be here with you today to give this lecture. As I sat through the opening morning greetings, and as I watched the film of Professor K.P. Chen's trajectory of his work over his life, I could not help but remember my favorite author, Maya Angelou's very simple words. And these words are, when you learn, teach, when you get, give. And as I reflect on Professor K.P. Chan's life, he is the embodiment of the beneficiary of a great education that he then gave to his students and his students' students and far more. And he has given global health equity to all in his life work. And for that, I thank you for your listening. I thank you for sharing and allowing me to share in the celebration of K.P. Chen's lasting legacy. Thank you.
We have a gift to present to you. Thank you, Professor Williams. The KP Chen Organizing Committee would like to express the deepest appreciation for this wonderful speech. Now we would like to invite the president of the foundation, Professor Ye Jingchuan, to present the gift.
Okay, so now we move to the fun part. We will invite a lot of your colleagues also serve as dean or former dean. So Dean Chang Qianzhang and Dean Jia, Dean Emeritus Fukuhara, and Vice Dean Kawakami, please come on stage. And more microphone. Okay. One. So our rule of praise, probably all 4 deans make a very brief response to Michelle's speech. And if we have time, maybe open to the floor for a few questions. So anyone like to start first? Maybe our host, Dean Chen.
Well, Michelle, it's a great talk. And what amazed me is, you know, it seems to me you have to read a lot of your faculty's research. And as the very fresh dean, you know, as how can you line up with so many diverse and talented and very eagles and researchers to work on a very important issue like aging? You know, they are working from different perspectives, but they never lose the focus on important issues. That's very difficult for me, you know, to say, come work with us on this topic. And it seems to me, at Harvard, you have this kind of very nice combinations, and it turns out become the leader in the public health research. So that struck me. And the other thing on this topic that we are kind of mired in this classical definition of aging population, age 65. I think it's very unrealistic now, but the whole society still think, you know, working towards 65 is the time for retirement. When I traveled to Malaysia before, they are retiring, the professors are retiring at the age of 56. You see, so it's appalled that now they increase, but you know, all this definition, you know, if you don't have measurement, you don't have science, right? Then our major, you know, for 65, I don't know what. So probably we have to dig out these origins and how to persuade our society to redefine what is biologically or psychologically aged population. So I would like to know some of the response from you.
Michelle, you have to have a good memory, so remember what he said. But then we move on to other comments. So at the end, you just respond in general. So Professor Jia or Hukara, you'd like to continue? Oh.
Yeah, I thought the comment that the problem of aging is actually against a bigger backdrop, bigger fabric of public health issues. And the point which I'll later make in my presentation that I'd like to highlight is that very often when we talk about aging, we tend to be focusing on those who are aging or the aged. But if we continue to do that, we will always be behind the curve. that to tackle the problem of aging is not just about looking at today's aged, but to tackle the problem of aging, we actually got to go further upstream. It's today's young, tomorrow's aged, that we need to start tackling. And so I think there's a danger sometimes when we talk about aging to actually be distracted by just focusing on those who are currently the aged.
Okay, so Dean Emeritus Fukuhara.
Sure, I'm really impressed with your talk, and your talk was very thought-provocative. Particularly, I was interested in your talk on social connectedness and end-of-life issue. Actually, back in 25 years ago when I was in Harvard Clinical Effectiveness Program, although I was a cardiologist, my final research question I conceived was end-of-life decision. And I'm really glad that we have just started a new collaboration project with NTU on this issue. On social connectedness issue, Ichiro Kawachi also did a wonderful study in Tohoku after disaster, before and after disaster. And he found out that people who have a stronger connectedness, elderly people who have a stronger connectedness, had a much better outcomes in terms of loss of independence after disaster. Now, my question to you is the US is so notorious for huge social disparity and poor social connectedness. I wonder what the role of a school of public health in leading university on policy or whatever.
Okay, so Vice Dean Kawakami.
Yes, first, thank you very much, Michelle. You're very excellent presentation. From your presentation, I have learned that probably we improve, actually we change our mindset or older view over the elderly, society, and maybe public health. Probably we need really figure out the new ways of the thinking, and also the acting in the community, get older age, aging community. So let me add our recent experience to your excellent keynote based on our new paper published in Lancet in the next September. In this paper, we analyzed the changing burden of diseases in Japan, national and also the sub-national levels by prefectures. And what we actually we found Japan did a very good addressing. So the life expectancy improved the 4 years between the last 20 years, but we only have the very small improvement in years lived with disability, only by the 4%. And also the prefecture gap in the life expectancy and daily increasing. And at the last, we found there's almost no association between health system input, like the health expenditure or number of physicians in the prefectures with these health outcomes. So probably the performance of the health system might be very different in quickly aging societies. So probably we need to be very careful to reanalyze our system for the public health and prepare for the coming aging society. So that's my feeling.
Okay, so now a real test for your memory. Yeah?
So let me start with the first point about how does one get faculty that is as diverse as ours, that includes life scientists, bench scientists, and health policy, all to bring their talents to address a challenging issue, such as the demographic shift we're seeing in aging and longevity. And I can say that the more complex the problem, and this is a complex one, the more intrigued and enthusiastic are our faculty. And as a dean, as you know, our goal is to provide the facilities and the resources so that our gifted and talented faculty and their students can address these problems. For me, the challenge is to be sure that we break down the departmental barriers, the tendencies that the disciplinary silos. These are complex problems that require working across disciplines. And so for me, the biggest challenge is to encourage and support working across disciplines and embracing the team science approach. It's also enormously gratifying to see young people come to public health today insisting on working across these disciplines. So I think it's for us to provide the resources and get out of the way and let the talent do the work that is needed. I want to address the health disparities issue because public health is about access to quality care, universal social justice. And the disparities that we see in the United States in particular is a challenge. And it is one that's going to require public health people and the lay public to raise their voices up against the social inequality and social injustice that exist. I'm personally excited about the movement towards personalized medicine, precision medicine. But as a public health person, I think first and foremost what we must do is to be sure that quality access to care is available to all. It is a human right. And so we have a long way to go, and we can learn many, many lessons from our colleagues here in Taiwan in having a universal health system that provides primary care to all. In doing that and approaching aging as a life course event, not just a focus on the aged, this will move us in ways where we can see not only people living longer, but living independently, healthier and happier for a longer period of time. It's more than just the number of years. It's about the quality of one's life over the years. And that is really a life course investment in social justice and healthcare as a human rights.
Fukuhara's question is about
On the social connections.
so yeah.
So you know, as a graduate of the Health Policy and Management program, you know how critically important it is for our school to have active faculty in the policy arena and in the leadership space. And one of the things I'm most proud of in public health, I like to say we are a university within a school because we do embody the scientists, the quantitative specialists, the life scientists, the policy and health communicators. And I think it's absolutely critical that when we generate new knowledge, we translate that knowledge and take that to our colleagues who work in healthcare policy to take it to the population scale level. So this is critically important. In the United States, as you know, we're under a bit of an extreme situation where evidence-based decision-making is under threat. But this is only temporary. It is our reality, but it is not normal, and it is only temporary. Policies are needed to be driven by the evidence that then allows us to support to the public why we need to do the things we do around providing health care, being thoughtful about sustainable decisions in how we raise food and how we use energy.
Looking at US and UK policy to improve quality of care, with the introduction of so-called pay for performance.
Yeah.
I think it seems to have functioned relatively well to implement evidence-based healthcare, whereas it would be really difficult, I see, to influence policy or public to be convinced that how social connectedness, for example, those health determinant of social determinant of health is so important for public health.
Yeah.
And change the policy and the people's behavior. I can't think of any specific measure to change it.
Yeah.
Do you have any idea?
Yeah.
Or
Yeah, so this is an important area, the social determinants of health, and the work that Ichiro Kawachi is doing is critically important. You know, when you think about how we live in increasingly urban settings. We live increasingly attached to communication devices that allow us not to have direct engagement, but indirect engagement across the internet. So one of the things that's being done in our Department for Social and Behavioral Health is to really think about how we encourage individuals to interact across the life course. One thing that I was particularly struck by many years ago was in our own cancer epidemiology work. We learned, prostate cancer, not necessarily a very deadly cancer. 95% of people diagnosed will not be the fatal outcome. But the interesting finding, repeated now across many studies, is that men who were widowers diagnosed with prostate cancer were more likely to commit suicide because of their social isolation and lack of connectedness to family and others. It wasn't the cancer, it was just the diagnosis. And this is another profound example of how important social isolation really is on the impact of how one receives a diagnosis that's not necessarily fatal. The other thing that was important is increasingly clinical trials are being shown that men with a diagnosis who are part of a treatment program where they are encouraged to interact with others in sports or book clubs, their cancer survivorship is much better. These are real. This is tapping into the human asset of engagement, social engagement, and we have a lot more to do. I think about the work of one of our faculty members, an epidemiologist, Tyler Vanderweel, a brilliant epidemiologist who also spends his time thinking about the role of spirituality and health. We have to work on finding better measures that are robust, have good construct validity, and are reliable across cultures to really understand how social connectedness, spirituality are important social determinants that contribute to our health and well-being. We have a lot of work to do.
Yeah. So, Paul, lastly, to address the Kawakami's comment.
Remind me your question.
Actually, I have no question. I just agree with you that we need a new view in public health in the aging society. But also, I think you guys discussed about the social determinants of health in the aging society, particularly focusing on the connectedness. But I read recently a very interesting short article published in JAMA, which that says the isolation might not be a social problem, but also the problem in people's mind. So the U.S. researcher conducted a very unique study and found that the one woman when she took the very special training, she found, oh, my happiness is living close to my daughter. So that's the source of my isolation. She moved to the place close to her daughter and then get her view. So I think that these new view might be very important, even in the agreeing with the social determinants. Yeah, but just my reflection.
Yeah. No, thank you for that. I really think that we have to be very thoughtful, and this is where qualitative studies, the emergence of focus groups and mixed methods research is going to be very helpful. I think most of us here are epidemiologists, but there's really going to be important added value in having the narrative, the personal narrative, added to the way we think about characterizing what really is social isolation. And it's going to be more than the typical survey. We really will have to listen intently and understanding how best to characterize this concept, and then think about interventions to address this.
Okay, the dialogue is much better than I imagined. But we are kind of running out of time, so probably if people like to ask you questions, you can chat with those speakers during the early break. So let's give a big applause to all the discussion speakers. Thank you. Thank you.